about things. Okay. So this is just so we started recording. This is a 73-year-old gentleman who's coming in with 3 weeks of cough and sputum production that has progressed to having dyspnea over the last 3 or 4 days, the background of a tobacco use disorder. So in terms of like dyspnea, I like to think about the dyspnea pyramid and thinking about the base rate of disease, with most often dyspnea is pulmonary and cardiac issues, pulmonary being the best, followed by cardiac. And then on top of that, then things that cause dyspnea, but not necessarily hypoxemia. So your acid-base disorder, anxiety, all that remains anemia, that remains a diagnosis of exclusion. So the other thing that helps hone us into the pulmonary system is the cough and sputum production for the prior 3 weeks. In terms of like the dyspnea itself, your no misdiagnoses are often like, in the realm of like your pulmonary embolisms, pneumothorax, all of those things. However, this is like more kind of a progressive. So getting vital signs sooner than later is helpful to determine if this patient is having hypoxemia or not. So in the realm of cough and sputum production for 3 weeks, we always like think about infectious etiologies. Usually, your pneumonias can lead to it. However, 3 weeks is a long time to be symptomatic. The question is like, with the background of tobacco use disorder, did this patient have an infectious etiology, like whether it's like a viral or a bacterial in bronchitis or the pneumonia that then triggered something like a COPD? I don't see a chart diagnosis of COPD, but I would like to get to know a little bit more about their background tobacco use. Common things being common. And if they have a significant background use in the 70s, that's something common to worry about. The other thing is, thinking about what else could be triggered, with tobacco use cause lung malignancies, no weight loss. It's helpful there. However, you can have malignancy without weight loss. So things that I would be thinking about is like getting more clarity on the background and also getting some physical exam to help me see what the lungs are doing.
Oh, so good. 3 lines of text and 3 pages of brilliance there. Sherman, I love it. So I'll just give a little bit more of the background to sort of clarify some of the things and then take you up through the physical exam, and then we can go from there. So in terms of rest of the review of systems that you mentioned, no orthopnea, no P&D, no lower extremity edema. In terms of the medications that he was taking, takes amlodipine and lisinopril for his hypertension. He's on a atorvastatin. And then has recently started taking metformin for some pre-diabetes. And then that's really it in terms of the relevant medications. Has occasionally uses NSAIDs and things like that. Family history, social history, unrevealing in terms of health-related behaviors, has about 1/2 pack per day over the last 40 years or so. Tobacco use history, no allergies. And then in terms of vital signs, had a temperature of 100.2, heart rate in the 90s, blood pressure was in the 110s over the 80s, sort of lives in the 140s to the 150s. And was satting like 90 to 92% on room air. In terms of general exam, oh yeah.
I lost the blood pressure.
Oh, that's okay. 110s over the 80s. And baseline blood pressures, like looking back from primary care visits and stuff, is in the 140s to 150s over the 90s. And then his O2 sat was like 90 to 92% on room air. And then in terms of general exam, not any acute distress, but looked tired. HEENT exam was unremarkable. Cardiac exam had flat jugular veins, like sitting up at 90 degrees. And then rest of the cardiac exam was normal. Lung exam had clear lungs on the left, bronchi in the right sort of upper lung fields, absent breath sounds, and some dullness to percussion in the right lower lung fields. And then was like coughing up, like it feels notable. I'm sorry if anyone has recently had breakfast, but like dense green, like gook at the bedside. The rest of the exam was normal.
Oh no, I am worried about this patient. So, and the temp was 100.2, right? So low grade temp, Jack.
Yeah, sorry, 100.2. Thank you.
So yeah, so in terms of kind of going back to the background information, I loved everybody mentioning lisinopril on the med list causing cough. I always like to look at the med list and think about like, is there any side effect of these meds that play here? So kudos to you all for doing the same. And in terms of like the half pack smoking history for 40 years, that is notable to keep in the back of our minds. In terms of the vitals, so this patient is inflamed. 90s, like he's on the border of being tachy, a border of being hypoxemic, and his blood pressure, if the baseline is like 150s, 160s, in the 1 teens, probably had taken his lisinopril this morning. This is the question that I would ask him. However, it's like a little softer. So again, this vital signs is not reassuring to me. And I think in terms of the CV exam, we said cardiopulmonary. It seems like with flat JVP, no lower extremity edema, we don't really think this is much of a cardiac process for now. Lung exam is like where the money is at and is where we were concerned about from the get-go. So the things that I am worried about is that, that cough and sputum production that started 3 weeks ago, what if that was like a bacterial pneumonia of some sort, and now we're dealing with like complications of it. So what can be the complications of, especially, people with COPD? Again, I don't know, this patient has COPD, but it's a substrate for having at least like underlying some pulmonary pathology, whether that is COPD, ILD, not being able to clear, as Jack said, well, so they're at risk of developing complications of that can be a pulmonary abscess or like effusions that can a lot of the times complicate pneumonias, and it's specifically like turning into an empyema that needs to be trained. And we don't really hear that much wheezing on exam. So at this point, like I definitely want some lung imaging. Chest X-ray is always a good place to start, but in a 73-year-old with that degree of symptoms, I might just go for my CT and just get a better sense of the parenchyma. The question is like whether you would give contrast in this case. I think with the contrast, you're evaluating the vessels. I would get a creatinine. My worry is mostly for the parenchyma, but sometimes like abscess, the contrast is helpful. You can always like talk to radiology if you have questions about what you want to visualize, but I would definitely, I'm leaning toward getting a CT. Start with the chest X-ray, but I think we might lead to a CT later on.
Right on. Ask and you shall receive. So white count 18, neutrophil predominant, hemoglobin 14, platelets were in about the 400s, slightly elevated on our assay. Metabolic panel was normal, including a normal creatinine. LFTs were also normal. I'll give you the chest X-ray and the CT scan. I think you narrated the analysis of the need for a CT scan brilliantly. So chest X-ray showed what looked like sort of a consolidative opacities in the right middle lobe, and what was initiated as a small to moderate pleural effusion. And then the CT chest, which we got with contrast, showed a couple things. It showed a right lower lobe nodule. It was about 3 centimeters. A right middle lobe dense consolidation with a question mark area of hypoenhancement. And what looked like some narrowing of the of like one of the secondary bronchioles leading into that consolidation. And then there was a big lymph node in the mediastinal area that looked to be causing some of that airway compression. So distant nodule, dense consolidation with some hypoenhancement in the right middle lobe that was looked distal to maybe some airway obstruction from a lymph node. And then there was a moderate pleural effusion that appeared to be layering, but there was some pleural enhancement.
Damn, don't love this. So just to make sure that I understand, the hypoenhancement, is it within the consolidation?
Yeah, so it's like there's consolidation like this. Like this, my hands are the consolidation and my face is the area of hypoenhancement in there.
Got it. So, with that, I worry about cavitary lung lesion as well. If that is some hypoenhancement inside that is like cavitating. So a couple notable things, kind of the nodule with a 3 millimeter the light lower lobe, that's a good one to keep a track on. The question is like, is that related to the rest of the presentations or not? And that's sometimes like good to get follow-up imaging to just check on that nodule. If it's part of the infectious etiology, then it resolves. If it's not, then you have to more worry about like a malignancy type. And then let's talk about the rest. So we have someone who is inflamed with that white count and the thrombocytosis that goes with it as well. So I'm kind of looking at that CBC and saying like this patient is inflamed. With the neutrophilic predominance, first we think about like a bacterial infection. Some of our solid malignancies can do the same. However, with this kind of a history of 3 weeks, the first thing I want to do is like think about my infectious etiologies. With this like consolidated mass, the question if this is like a cavitated lung lesion of some sort of abscess formation would be the first that I worry about, and especially with the abscess, then thinking about anaerobic coverage might be a good idea. And then with the pleural enhancement, within thinking about whether this is complicated by kind of a pleuritis of some sort. So this is a person that I would see if there's a pocket to get a diagnostic thora. If there's any septations, we might have to get help from our IR colleagues. But this is someone that I would definitely with a little bit more information. But in terms of like activating my schema for like cavity lung lesion, the big buckets, our favorites: infections, malignancy, autoimmune. There are others like PE with infarction of some sort. Jack and I once with infarction got a better of us. So not to myself to never forget that. But I think in terms of like infections, in terms of like acute, like your necrotizing type of infections are the one that you most worry about, like your Staph aureus, your Klebsiella is another good one to think about. And then but any of the lung bacteria can cause infection, can cause abscess formation, especially if there is some difficult with immunity that is going on. But in the subacute world, you think about fungi and parasites as well, like crypto, for example. The other one that I was like think about, this one is like kind of a big one consolidated region. So it kind of sounds like to me a place that was like infected and couldn't get cleared. However, the one thing I never want to forget is endocarditis with septic emboli. Again, we're not getting a flavor for that. However, this is someone that I would get blood cultures in, because the question is like, with that bad of a consolidations, then are you having systemic infection as well? So at least like a blood culture in addition to your sputum cultures would be a good thought here. So if I'm Jack, this is a patient that I would definitely want to admit, start IV antibiotics, definitely something with and gram negative and anaerobic coverage. The question is like, would you also put some VANC on or some gram positive? And I think that's where your MRSA near is helpful. It has good negative predictive value. If it's negative, then less likely. However, I would start broad. I would get my blood cultures, my sputum culture, get the MRSA near, try to see if there's a pocket thora to get better information about what this is. And bacterial is like first on my diagnosis. However, I want to be open to fungal infections causing the same thing. And the background, then we also mentioned autoimmune and malignancy. Malignancy is a good thought, but I would first make sure this patient is not acutely infected before going and thinking more about malignancy.
Oh, I love it. I will give 2 more pieces of data and then for you to discuss, and then the final diagnosis. So there was this sort of like, I think you narrated it so perfectly, Sherman. There was this sort of like swirling links in the chain of like cancer, underlying infection, and then the possibility also of a pleural space infection. And it's like, how is this nodule relating to it? What is this lymph node doing? And how do we integrate these things together? And so this patient actually went to a PET CT the next morning after he was admitted, and put on the exact antibiotic coverage that you suggested. And the PET CT, so there was this nodule in the right lower lobe that was again separated from this hypoenhancing consolidation. And that nodule was not hot on the PET CT. So it was thought to be most likely a hamartoma. The lymph node was also not hot on the PET CT as well, but it was like sizable. It had some metabolic activity, but not a level that the radiologist felt like was compatible with underlying metastatic malignancy. But then this consolidation, I wish I had the picture here. The consolidation had this beautiful hot ring enhancing to it. So like the whole periphery of this consolidation was hot on the PET CT, and the center of it had really no metabolic activity at all. And then there was some increased activity kind of on the pleural surface as well. And then we got a diagnostic thoracentesis. And the pleural fluid protein was 4.5 with a serum of around 7.5. The pleural fluid LDH was in like the 600s with a serum in the 400s. The pH in the pleural fluid was low, like 7.1. And the glucose was like, I think like 15 or 18, but also low. Gram stain from the pleural fluid was negative, and talking to the interventional radiologist, she was like, it didn't seem purulent when they did the test. That's all I got.
Oof. PET scan has become such a good tool for us.
Yeah.
I love it, like especially like endocarditis, sometimes it just lights up. So yeah, and I think that the tension, especially in the older gentleman with that significant tobacco use between like infection and malignancy, is a real one. So kudos to you guys for investigating both. And I think for now, again, we're kind of still most worried about an infectious etiology and kind of looking at that pleural effusion and those studies. We use the Lights criteria that takes into account the pleural protein and LDH, and the goal of that is to catch as much exudative processes as possible, because that's what you're worried about, right? And And this is good. And I haven't done the exact calculation, but sounds exudative to me. Not gonna do math live. That's my rule number one. I am no Robbie Jiha. And the thing that I'm worried about is that, with that pH being low, that is a complicated effusion. If the pus was there, most worrisome for empyema. But honestly, like for me, this is empyema-like until proven otherwise. And that's how I would kind of treat it. And I think the question of with that is like, oh, they requires oh, hey. Hi, Archie. Didn't realize you're here. What a great surprise. I think with that, the question that I worry about in the pleural space, especially with the pH that is that low, I think the glucose was low as well, is that, if my antibiotics are going to get there and if that is truly going to be infected. So I have a low threshold of like having a catheter there to make sure that we clear that space out in addition to being IV antibiotics and wait until my blood cultures come back. If the blood cultures doesn't come back, then you want to have an antibiotic regimen that is broad for now. Again, like sputum, blood cultures, get as much data as possible. So I'm still like kind of most worried about a bacterial infection that has kind of led into a necrotizing kind of abscess formation plus an effusion. But I'm curious as to how you guys were thinking about it.
Exactly as you just said. Yeah, our working hypothesis, or sort of the diagnosis that we ended up assigning to it, was exactly as you said. Basically, a necrotizing pneumonia / lung abscess. Given that there wasn't quite a true air fluid level in there yet, it was sort of on the spectrum of necrotizing pneumonia to lung abscess. But the ring enhancement on the PET CT was very much looked like sort of developing lung abscess. And then exactly as you said, complicated parapneumonic effusion. The cultures from the pleural fluid, the sputum cultures didn't end up growing anything. The patient didn't need a bronchoscopy, so we didn't end up getting any sort of deeper tract, respiratory tract specimens. But the pleural fluid ended up growing a mix of Viridan strep, Propionobacterium, Peptostreptococcus as well. So this sort of combination of basically oral flora, including some oral anaerobes. And that was managed also not only with antibiotics, but also a chest tube, as you had mentioned. So yeah, final diagnosis was a lung abscess with a ipsilateral complicated parapneumonic effusion / empyema.
Wow, what a case. Jack, thanks so much for presenting.
Yeah.
Love thinking through it. And I think you all in the chat, I think Anne-Marie initially also pointed out that like a good oral exam in this patient. I just wanted to highlight that. Absolutely a great point there as well. Thanks all for helping me think through this. I am always amazed by the incredible knowledge in the chats. All right.
So wait, I just want to before turning it over to David, I just want to say like the reasoning piece of it that I think was like so critical that I worry was potentially subtle at the beginning was just how right away you're like, this could be a pulmonary infection, but the time course is too long for that. And it's like already floating the more complicated pulmonary infections right there of the moving from like 3 days to 3 weeks. I was like, as soon as you said that, I was like, oh, she's gonna get this case. So it was awesome.
You always set me up too well, Jack. You'll set me up very well.
No setup needed. You can alley-oop anything.
Thanks, friend. I'm the one blushing. See how tables have turned. All right, David, we're ready for you.
Okay, so great case, and that began with the chief complaint of dyspnea that could be arranged in different categories, prioritizing pulmonary and then cardiac diseases. In the pulmonary bucket, we find a lot of diseases, but in this context, with cough, sputum, and signs of inflammation, we have to prioritize an infectious or cause. If due to the acute of the illness, without keeping in mind that malignancy is another great possibility. In this case, there was a great discussion about the possible complications of pneumonia, given the imaging findings. Some of these complications could be the lung abscess, the effusion that in the beginning could be parapneumonic, but could then complicate and become also an empyema. And well, there are other complications such as microemia, sepsis, or ARDS. It was also reminded that in this case we should add anaerobic coverage given the findings. This coverage is indicated when empyema, abscess, necrosis, or microaspiration with septic mouth or periodontal disease is found. There's this great paper in the Things for No Reason in the journal. I don't know how was the name now, but that you think that the anaerobic routine coverage is not needed for aspiration pneumonia. Only these features are present. Then in this case the presence of necrosis makes prioritize some particular etiologies such as Staphylococcus aureus, Klebsiella, Pseudomonas, Haemophilus influenza, nocardia, pneumonitis, or well, in this case it was Bacterium, and well, the final DX was given by also the thoracentesis that showed features consistent with complicated parapneumonic effusion. It doesn't get to the empyema, I think, because the absence of pus, but well, it was the final diagnosis that it's can be a very aggressive disease, but hope the patient will be fine. And thank you for the discussion.
David, thank you so much for summarizing those teaching points so well. That was awesome. Well, thanks again, everybody, for coming out. We look forward to seeing you next week. Steph and Zavin will be back next Wednesday. But I hope everyone has a great rest of the week. And yeah, get excited for next week's Wednesday session with Steph and Zavin. And we'll see you back here in a couple of weeks. Thanks, y'all.
Thanks, all. Beatrice, thanks for describing. David, awesome teaching points. Jack, thanks for presenting, and all of you for helping me out with this case. See you later.